Welcome to the Deep Dive, where we take complex topics, your essential sources, and really try to turn them into clear, actionable knowledge. Today, we're plunging into a world it's absolutely critical for every single medical practice, yet often remains a bit of a mystery if you're outside of it. Accounts receivable follow-up in medical billing.
Yeah, it might sound like, purely administrative jargon, maybe something tucked away in the back office somewhere. But what we're really talking about here is the financial heartbeat of healthcare providers. It's about making sure they actually get paid for the vital services they provide.
The heartbeat, I like that.
And when we zoom out, this whole process, it directly impacts a practice's ability to just keep its doors open, right? To hire and keep skilled staff, maybe invest in new diagnostic equipment, and fundamentally just continue caring for patients. Without diligent AR follow-up, the entire system it can seize up pretty quickly.
That's a really powerful way to put it. So our mission today is to cut through that complexity. We want to give you a shortcut to being genuinely well-informed about this really crucial aspect of healthcare finance. We've got a fantastic guide here, an accounts receivable follow-up guide that lays out the detailed process. We're going to unpack its core insights, maybe discover some surprising facts that might change how you view billing, and help you understand what's truly important about managing money owed in medical billing. So let's dig in.
Okay, let's start with the basics then, because before we can really dive into the follow-up part, we need to understand exactly what we're following up on. Our guide defines accounts receivable, or AR, pretty simply. It's the money owed to a healthcare provider for medical services they've already rendered.
Right.
It's not just, some abstract line item on a balance sheet. It's the pending income that genuinely keeps the lights on, pays the nurses, the medical assistants, buys critical supplies. Think of it like the promise of payment for really vital work that's already done, but crucially, it's a promise that requires active pursuit. And what's often overlooked, I think, or maybe it's a surprising fact for many, is just the sheer volume and, frankly, the vulnerability of this pending income. Studies consistently show that a significant chunk, a really big percentage of claims submitted by providers are initially denied or just never fully collected.
Wow.
We're talking potentially billions, literally billions of dollars annually in lost revenue across the whole healthcare system. And not because the services weren't provided, right? But because the payment for them got stuck somewhere in that AR pipeline. This just highlights why active follow-up isn't really optional. It's absolutely essential for survival.
Billions. That's staggering.
It really is. Now, digging a bit deeper, AR primarily comes from two main sources, and each one has its own distinct follow-up and nuances, almost like two different species of outstanding debt that need tailored approaches. The first, and usually the largest chunk by far, comes from insurance companies. This is all about unpaid claims. You see, when a patient gets care, the provider bills the insurance company based on the services covered by their policy. Pretty straightforward, you'd think. But until that payment is actually received and cleared, that outstanding amount just sits there in AR as a pending claim. And this can involve these complex webs of coding, medical necessity rules, varying payer policies. It makes it a constant dance between the provider and the insurer.
A dance, yeah. I can imagine.
The second major source of AR is patients themselves. Now, this covers a variety of patient financial responsibilities that might seem straightforward on the surface, but can actually be quite complex in practice. For instance, you've got copays, those fixed amounts usually paid right at the time of service. Then there are deductibles, which is the amount a patient has to pay out of pocket before their insurance even starts chipping in for covered services.
Right, the deductible hurdle.
Exactly. Then there's coinsurance. That's a percentage of the cost of a covered health service you pay after you've met your deductible. And maybe most frustrating, for patients and providers alike, patient balances can also pop up from claims that were initially denied by insurance. So the insurer refused to pay, and that financial responsibility then shifts directly onto the patient's shoulders. Each of these patient-owed amounts needs its own careful, often quite sensitive follow-up strategy. You're balancing collection with trying to maintain a positive patient relationship.
Yeah, that sounds like a tightrope walk. So as you can hear, this isn't just about sending out a bill and then, passively hoping for the best, maybe crossing your fingers that someone somewhere eventually decides to pay it. The guide really emphasizes that AR follow-up is the process. It's about actively tracking and meticulously resolving these unpaid claims or patient balances. It's very proactive, hands-on, almost investigative, you could say.
Investigative is a good word for it sometimes.
It's about ensuring timely reimbursement, which, as we've already touched on, is absolutely crucial for a practice's financial health. It's almost like this persistent yet hopefully polite pursuit of what's rightfully owed, but with just an immense amount of administrative complexity bubbling underneath.
And when we think about the bigger picture here, AR follow-up isn't just some isolated task sitting off to the side. It's a core, absolutely critical component of something much larger, known as revenue cycle management, or RCM.
RCM, okay.
Yeah, RCM is this overarching process. It encompasses everything from the very first patient contacting, patient registration, scheduling, verifying insurance eligibility, collecting those copays upfront, all the way through to the final payment collection and closing out the account. It's the entire financial journey of a patient encounter, really, from the moment they walk in the door until that last dollar is collected.
The whole life cycle.
Exactly. And within that journey, effective AR follow-up directly and profoundly impacts the cash flow of a healthcare provider. A steady, predictable flow of cash means a stable practice, period. Without that stability, it's incredibly difficult to plan for the future, to innovate by investing in new tech, or even just to maintain current operations. I mean, imagine a situation where a clinic just can't reliably pay its nurses, or buy new surgical instruments, or even keep the lights on because the money for services they already provided is just stuck in administrative limbo.
Yeah, that's a bleak picture.
It is. That's the stark real-world consequence of a failing AR follow-up system. It's not just about profit margins. It's about the fundamental ability to deliver care. This process is essentially the financial feedback loop that keeps the whole healthcare delivery system functioning.
So, okay, why do practices dedicate so much time, so much effort, and frankly, entire departments to this? Our source breaks down the key objectives, and when you look at them, it's pretty clear they're all intrinsically linked to financial health, operational efficiency, and ultimately the practice's continued ability to provide high-quality care to its community. It's definitely not just busy work, it's deeply strategic.
You're absolutely right. These goals are highly strategic. They're aimed squarely at ensuring the long-term viability and hopefully growth of a practice. Firstly, the primary objective, the big one, is to maximize revenue. And this isn't just about getting some money back. It's about ensuring all claims are paid fully and correctly according to whatever contracted rates they have with payers.
All the money they're owed.
Exactly. Every underpayment, every denial that just goes unchallenged, every overlooked patient balance represents lost revenue. Money the practice legitimately earned but hasn't actually received. For, say, a mid-sized practice, just a few percentage points of uncollected AR can mean the difference between just breaking even and being profitable enough to maybe expand services or offer better patient programs. It directly hits their bottom line, right? It prevents them from using those funds for patient care improvements or necessary operational stuff like upgrading their electronic health record system.
Makes sense.
Secondly, the guide highlights the objective to reduce days sales outstanding, or DSO. This is a really important metric in finance generally, not just healthcare. It represents the average number of days it takes for a practice to collect payments after a service has been rendered. Think of it as a measure of how quickly your rendered service transforms into actual spendable cash in the bank.
How fast the money comes in.
Precisely. Minimizing this time is crucial for liquidity. A lower DSO means money is coming in faster, which directly improves cash flow. For instance, if a practice can shave just, say, 5 days off its DSO, that could free up thousands, maybe even tens of thousands of dollars in capital almost immediately.
Wow, just 5 days.
Yeah, and that freed up capital could then be used for urgent payroll, maybe a critical equipment repair, or seizing an opportunity to invest in some new technology that improves patient outcomes rather than just covering basic operating expenses. A high DSO, on the other hand, means you're waiting a long time to get paid, leading to potential cash flow shortages and, frankly, a lot of operational stress.
I can imagine.
Thirdly, practices aim to resolve claim issues. This objective involves actively tackling their whole myriad of common problems that plague medical billing. Things like outright denials, where the payer just says, nope, not paying. Or underpayments, where they only pay a portion of what's owed without a clear reason.
Or sometimes no reason at all, right?
Sometimes, frustratingly, yes. Or claims that just get no response at all, seemingly vanishing into some administrative black hole. It's about proactive problem solving. This isn't just about spotting the problem, it's about having a systematic approach to fixing it. Whether that means correcting a subtle coding error, drafting a really compelling appeal for an unfair denial, or just rigorously resubmitting a lost claim. Every unresolved issue is a tangible loss, both in revenue and the administrative time spent casing it.
Right, time is money too.
Absolutely. And finally, a crucial, maybe the most critical goal is to maintain healthy cash flow. This brings us right back to that steady, predictable stream of incoming payments we mentioned. Predictable cash flow is really the engine that allows practices to operate smoothly. It lets them pay staff reliably, on time, which is essential for morale and keeping good people. It enables them to invest in new equipment or technology, expand services to meet community needs, or even just cover unexpected costs, like a sudden jump in the utility bill or a broken piece of machinery. Without it, practices can find themselves constantly in this state of financial precariousness, unable to grow or even sustain their current operations, just constantly worrying about shortfalls. Ultimately, it allows them to focus on their core mission, patient care, rather than being distracted by the relentless pursuit of every last dollar.
So, for you listening in, understanding these foundational goals really helps frame why all the detailed steps we're about to explore are just so essential. It's not just, shuffling paperwork or obscure administrative tasks. It's truly about the financial survival and sustainability of healthcare providers. It's the difference between a thriving clinic that can keep serving its community with great care and one that's struggling just to keep its doors open, potentially impacting patient access and the quality of care for everyone. Now, with that groundwork laid, how do practices actually do this? What's the practical workflow look like? Let's get into the nitty-gritty, the step-by-step process outlined in our guide. This is where the rubber meets the road, where strategy turns into action, and where efficiency truly, truly counts. It's a very systematic approach designed to maximize collections and minimize those painful delays.
Okay, the very first step, the absolute starting point for any effective AR follow-up process, is to review and categorize the AR aging report. This isn't just any old report, it's a crucial financial document. It serves as the kind of command center for AR follow-up. Think of it as a snapshot of all the outstanding money owed to the practice, but crucially, organized by how long that money has been outstanding. It gives you an immediate, almost color-coded view of the financial health of your outstanding claims.
Like a weather map for your receivables.
Exactly, a weather map. I like that. This report categorizes claims into specific aging buckets typically. 0 30 days, 31 60 days, 61 90 days, and then the worry zone, 91 120 plus days. Each bucket represents a growing level of concern because claims generally get harder to collect as they get older. And here's a key insight. The older a claim gets, the significantly lower the probability of collecting on it becomes.
Really? Is there a sharp drop-off? Oh, absolutely. Many payers have strict timely filing limits, often around 90 to 180 days from the date of service. So a claim sitting in that 91 120 plus day bucket is already deep in dangerous territory, risking automatic denial just for being filed too late. This is why the guide stresses strategic prioritization. Practices must focus relentlessly on older claims first, especially those 60 days or older, and also naturally on high-dollar claims. Why? Because the older it gets, the harder it is to collect expired filing limits. Patient memory fades, administrative momentum is lost. And high-dollar claims, obviously, have a much bigger and more immediate financial impact if they remain unpaid. Addressing these first directly impacts that DSO we talked about, getting those larger, older sums into the practice faster, literally saving money from evaporating. Okay, so you've got the aging report, you've prioritized what's next.
Once that comprehensive report is reviewed and the priorities are set, the next logical step is to identify outstanding claims. This is where the real detective work starts. You're pinpointing exactly which specific claims need immediate attention within those high-priority aging buckets. You're not just looking at totals anymore, but at specific patient accounts, specific services rendered that are somehow stuck in limbo.
Getting granular.
Very granular. The guide lists several common scenarios you'll be looking for here, and each one demands a slightly different investigative approach.
You might have claims with just no response from the payer at all. They seem to have vanished into the digital ether after you submitted them, leaving you totally in the dark about their status.
Frustrating.
Incredibly. Or perhaps you're looking at denied claims, which means the insurance company actively refused payment, sometimes for a stated reason, sometimes infuriatingly, for no clear reason that's immediately obvious. There might be partial payments where the payer only paid a fraction of what you expected, leaving a significant unexplained balance. Sometimes claims are legitimately still under review, stuck in a processing queue with the payer, maybe because they're complex or need manual eyes on them. And then their claims returned for corrections, often due to a minor fixable error that just stopped initial processing. Accurately identifying these distinct scenarios is absolutely key to knowing what specific action to take next. You can't treat a denial the same way you treat a claim that's just pending review.
Absolutely. And before anyone even thinks about picking up the phone or logging into a payer portal, the next step is analyze claim details. This is critical, often overlooked pre-contact due diligence. It's about ensuring you're fully armed with accurate information before you engage. And this raises an important point. Why is this preliminary step so crucial? Because going into that conversation, that interaction, with incomplete or incorrect information is just a recipe for frustration, wasted time, and probably further delays.
Right, you'll just get stonewalled.
Exactly. You simply won't get the answers you need, or worse, they'll just tell you to call back once you have the right details, wasting everyone's time. The guide stresses verifying crucial information. This includes the date of service. DOs, is it accurate? Is it within timely filing limits? Double-checking patient demographics. Simple errors here like a misspelled name, wrong birth date, outdated address are incredibly common reasons for initial denials.
The simple stuff trips you up.
Always, insurance information must be absolutely spot on. Policy numbers, group IDs, effective dates. Critically, you must confirm the correct diagnosis, ICD, and procedure, CPT code. Need to directly determine medical necessity and how much you get reimbursed. You also need to know the exact claim submission date and method electronic.paper to understand if timely filing is even potentially an issue. And finally, gather any existing payment or denial information you've already received, including those pesky denial codes. This comprehensive review prevents so much rework. An inaccurate modifier on a CPT code, for example, can kill an entire claim. Catching that before you call the payer saves immense time. It's about doing it right the first time, or at least having all the right data ready to quickly fix any problems that come up during the follow-up call. It really sets the stage for productive interaction, ensuring you don't waste time on easily avoidable issues that could have been spotted internally.
Okay, armed with all that verified info, now we get to the interaction phase. Contact the insurance company. This is where the actual engagement begins, and yeah, it's definitely not always as simple as just picking up the phone anymore, is it? The landscape of insurance communication has really diversified, driven by tech and just the sheer volume of claims.
It really has.
Our guide notes a variety of methods for this critical contact. Of course, there are still phone calls to payer hotlines. These can be super time-consuming, often involving those infamous long old times, but they are frequently necessary for truly complex or nuanced issues that just require a direct conversation. Increasingly, though, practices rely heavily on payer portals. These are the online gateways provided by the insurance companies themselves. Things like Availity or Navanet are big ones. These portals are becoming incredibly vital. You can check claim status, submit appeals, access patient eligibility info efficiently, often getting immediate updates without needing to talk to a human.
Which is a lifesaver sometimes.
Totally. You also have clearinghouse status tools. Remember, the clearinghouses act as intermediaries. They often offer a basic status check, giving an early hint if a claim was received and accepted for processing. Each method offers different levels of efficiency and detail, and a smart billing team uses all of them strategically, choosing the right tool for the specific task.
Absolutely.
So once you're connected, whether it's by phone or through a portal, it's absolutely essential to know exactly what to ask. The guide highlights key questions. You need to nail down the precise claim status. Is it still in process? Has it been denied, rejected, just pending? If there's a problem, you absolutely must get the precise reason for any delay or denial, often referenced by specific codes. That reason is paramount for figuring out your next move. And finally, you need to ask clearly what required documents or corrections are needed from your end to get that claim moving forward. Without this specific detailed information, you're essentially just flying blind, and that's a recipe for repeated efforts and mounting frustration.
And here's a critical, sometimes underestimated part. Documentation is key. You absolutely must rigorously record all communication details. That means the exact date and time of the interaction, the representative's name or ID number if you got one, the specific claim status they gave you, any reference numbers provided for the call or issue, and crucially, the agreed-upon next steps and the expected timeline for those steps.
Every single detail.
Every single detail. This isn't just, good practice. It's absolutely vital for continuity and accountability. Imagine a complex claim that takes multiple interactions over weeks, maybe even months. If a different staff member has to pick up that claim later, maybe because someone's out sick, on vacation, or even leaves the practice, they have complete accurate history right there. They can pick up exactly where the previous person left off, avoiding redundant efforts, not asking questions that have already been answered, or worst of all, missing crucial steps or deadlines that could cost real money. This meticulous digital trail is truly the backbone of effective AR follow-up. It saves immense amounts of time and prevents claims from just falling through the cracks.
Makes perfect sense. Okay, so you've contacted the payer, you've got the info, you've documented everything meticulously. What happens next?
Based on the information gathered from the insurance company, the next step is to take appropriate action. And this is definitely not a one-size-fits-all situation. Different responses from the payer require vastly different specific actions. This really highlights the nuance and, frankly, the expertise required in AR follow-up. It's like having a detailed playbook ready for every possible scenario.
Okay, let's break down that playbook. What are the common scenarios?
Right. So the guide outlines several key ones. First, if you have a denied claim. This is often the most complex and time-consuming scenario. You first need to analyze that denial reason. Payers use standardized codes like CR-ARC, Claim Adjustment Reason Codes, and RRRC Remittance Advice for Mark codes to explain why they denied it.
Alphabet soup.
Pretty much. Understanding these codes is like deciphering a secret language of denials. For example, SCIR-4 might mean the procedure code is inconsistent with the patient's age, or RRR, say MA01, could indicate missing or incomplete documentation. This is where reading the key leaves comes in, learning to read these codes not just for this denial, but to spot patterns that might indicate a systemic issue in your practice's coding or documentation. Once you understand the why, you have to correct the identified issues. It could be a simple coding error, maybe a missing prior authorization, or a medical necessity dispute that needs more clinical notes. Then you either resubmit the claim with the corrections or, if it's appropriate, submit a formal appeal.
An appeal sounds serious.
It is. An appeal is a formal request for the insurance company to reconsider their decision. It often requires a more detailed argument, supporting clinical documentation, and you have to adhere to strict appeal deadlines. This can even involve multiple levels of appeal, from internal reviews all the way up to external independent reviews sometimes. Now, a rejected claim is typically a simpler, more upfront issue. Rejections usually mean the claim wasn't even processed by the payer because of basic, often administrative errors. Things like incorrect patient demographics, misspelled name, wrong birth date, an invalid insurance ID, or maybe a missing referring physician. The claim essentially gets kicked back immediately.
Like a bounced email.
Exactly. The action here is straightforward. Fix those identified errors and immediately resubmit. It's like a form being returned because you forgot to fill in a required field. It just needs a quick correction to get back in line. If there is no response from the payer, despite you submitting the claim and enough time passing, the usual action is to resend the claim. This can happen for various reasons, maybe a technical glitch in transmission, maybe it just got lost internally at the payer. If repeated attempts still yield nothing, or if a significant amount of time has passed, say beyond 45-60 days, then it might be necessary to escalate the issue. Maybe contact a supervisor or try a different communication channel. For an underpaid claim, where the payer reimbursed less than you expected based on your contract, you need to request a clear explanation for that underpayment. This often involves comparing the payment you received against your practice's specific contractual agreement with that payer. If their explanation isn't satisfactory, or if it indicates an error on your part, like incorrect coding that led to lower pay, you might need to submit a corrected claim or formally challenge the payment amount.
And finally, if a claim is simply pending review, meaning it's still actively being processed by the payer, the immediate action is mainly just to set a clear reminder for future follow-up. There's no immediate action needed beyond waiting, but you absolutely need to know when to check in again. You have to ensure it doesn't fall through the cracks or drag on past normal processing times. If it stays pending way too long, it might then move into that no response or even escalation category.
Wow, okay. That really drives home the need for specific knowledge. Each of those demands a different skill set, almost.
It really does. Each action category requires specific understanding of billing rules, coding, payer-specific requirements, plus precise execution just to move that claim forward. A misstep in this phase can lead to more delays or even a complete loss of revenue. That's why comprehensive training for billing staff is just so incredibly vital.
Building on that, the sixth step, documentation and tracking, feels so vital. It really deserves its own dedicated spot here, even though we've kind of touched on it already. This isn't just about taking good notes. It's about maintaining this living, breathing digital history of every single claims journey. It's your undeniable record, right?
Absolutely, your audit trail.
The guide strongly emphasizes updating the billing system with detailed follow-up notes. This means not just what happened, but when you took action, who you spoke to at the payer, including their rep ID if possible, what they actually said, any reference numbers provided, and crucially, the current claim status and the next follow-up date. Why is this so vital? It ensures continuity and accountability. Think about a complex claim requiring multiple interactions over weeks, maybe months. If a different staff member has to handle it later, maybe due to a shift change, vacation, someone leaving, they have that complete, accurate, unassailable history right there.
Not starting from scratch.
Exactly. They can pick up precisely where the previous person left off, avoiding redundant efforts, not asking questions already answered, or worst case, missing crucial steps or deadlines that just lead to lost revenue. This meticulous digital trail is the absolute backbone of effective AR follow-up. It saves enormous amounts of time and prevents claims from just falling through the cracks, quietly becoming uncollectible.
And sometimes, despite all that diligent follow-up and meticulous documentation, some claims just get stubbornly stuck. You've done everything by the book, checked all the boxes, but the payment still isn't coming through. That's when the process moves to escalation. And this isn't a sign of failure necessarily. It's more of a strategic necessity and acknowledgement that a different, maybe higher level of intervention is needed to finally resolve the issue.
Okay, so what does escalation look like in practice?
The guide outlines several levels. If repeated follow-up through the standard channels, calls to the general inquiry line, basic portal checks just fails, the first step often involves escalating to a supervisor or a payer manager at the insurance company. This gets the issue in front of someone with potentially more authority who might have access to different internal tools or insights to investigate the delay or denial. If that doesn't yield results, or if the denial is particularly complex or persistent or involves a substantial amount of money, the practice might need to submit formal appeals or reconsideration requests. These go through a more structured, often written review process within the insurance company itself. This can involve multiple levels, internal, external, each with its own deadlines and specific requirements.
So more formal processes.
Definitely more formal. And for very large or critical claims, or maybe when there seem to be systemic issues affecting multiple claims with one specific payer, it might even be necessary to involve provider relations at the payer organization. These are folks whose job is specifically to act as dedicated liaisons between the insurer and healthcare providers. In extreme, hopefully rare cases, legal counsel might even get involved, but that's certainly a last resort, not the first step.
Right.
What's truly insightful here, I think, is that escalation isn't about just making noise or complaining. It's a calculated strategic necessity. It means recognizing when a claim needs that higher-level intervention to get resolved and having the persistence and the process in place to pursue it effectively. It's about exhausting all available avenues to recover revenue and understand that some issues simply won't be resolved at that first tier of interaction. It requires deep institutional knowledge of the payer's internal processes and, frankly, a clear understanding of when to push harder for what's legitimately owed.
Makes sense. Now, while so much of AR follow-up involves navigating the often tricky waters of insurance companies, it's really important to remember the other side of the coin, patient follow-up. Even after insurance has paid whatever share they're going to pay, patients often have a remaining balance due. And collecting from them requires a different, often much more delicate approach that has to balance financial recovery with maintaining patient satisfaction.
A very delicate balance, yes.
The process typically kicks off once the insurance company has paid their portion and an explanation of benefits, or EOB, has been received. That EOB clearly defines the patient's remaining responsibility, their copay, their deductible, or coinsurance amount. At this point, the patient gets billed for that remaining balance. Our guide suggests a proactive and, importantly, flexible approach here. It's absolutely crucial to offer payment plans when necessary. I mean, many patients simply can't afford a large lump sum, especially after a significant medical event, right?
Absolutely not.
Offering a structured, manageable payment plan significantly increases the likelihood of collection, even if it takes a bit longer, and it really enhances patient goodwill. This feels like a key insight. Flexibility often leads to higher overall collection rates and definitely better patient relationships than just aggressive, inflexible demands.
That relationship piece is huge.
Totally. Beyond payment options, consistent, empathetic communication is key. This means sending statements or reminders at regular intervals, typically every 30, 60, and 90 days. And these aren't meant to be aggressive demands, but rather polite, clear reminders of the outstanding balance. They should be easy to understand, clearly breaking down what the patient owes and why. This consistent yet measured approach helps patients manage their portion of the bill and significantly improves collection rates just by keeping the balance top of mind without being, overwhelming or threatening. It acknowledges that patients might need time or reminders, and it's about making it as easy as possible for them to fulfill their financial responsibility. It really is a delicate balance between persistence and empathy, recognizing that for most patients, medical bills are a significant financial burden.
Couldn't agree more.
Now, this complex, multifaceted process we've just walked through requires specific, often sophisticated tools to manage efficiently. You certainly can't just rely on sticky notes and basic spreadsheets anymore, not at scale. Our source lists the essential ones that really form the digital backbone of modern medical billing and can truly accelerate the AR follow-up process.
You're absolutely right. These tools, when they're integrated and used effectively, are genuine efficiency drivers. They help move practices from that reactive firefighting mode to a more proactive management stance. Let's dive into what the guide highlights. First up, we have practice management PM systems. These are really the central hubs of a medical practice's administrative and financial world. They manage pretty much everything from patient demographics, scheduling appointments, all the way through billing and claims submission.
The mothership.
Kinda, yeah. Often they integrate seamlessly with other tools, acting as the primary repository for all patient and financial data. Without a robust PM system, managing AR at any significant scale would be virtually impossible. It's where that AR aging report itself is generated, and it's where all those crucial follow-up notes are meticulously logged.
Okay, what else?
Next, clearinghouses play a vital, often kind of unsung role. These act as intermediaries between the healthcare providers and the insurance payers. Their main job is to scrub claims for errors, checking for missing info, incorrect codes, formatting issues before sending them off to payers.
Like a quality check.
Exactly,
Yeah.
a quality control firewall. This pre-submission error checking dramatically reduces the likelihood of those initial rejections and denials, saving countless hours in follow-up later. They also often provide basic claim status updates, giving you that early indication of whether a claim was received and accepted for processing by the payer.
Got it.
Then, as we discussed earlier, insurance portals are increasingly vital. They've really revolutionized the speed of AR follow-up in many ways. These are the payer-specific online platforms, Availity, Navinet, regional ones too. They allow direct, secure interaction with individual insurance companies, offering a much more detailed view of claim status, the ability to submit appeals or corrected claims directly online, and instant access to patient eligibility and benefits info. They often let you bypass those long phone hold times, providing immediate, self-service access to critical information. That directly impacts a practice's ability to reduce DSO by getting real-time updates. It's a genuine game changer for efficiency.
Yeah, avoiding hold music is always good.
Always. Now, even with sophisticated systems, spreadsheets or AR work lists are still commonly used. Sometimes they're built into the PM system, sometimes they're supplementary external tools, like Excel. These are crucial for detailed tracking and assignment of claims to specific billing staff. They allow for customized prioritization, granular notes, setting specific reminders that might be more flexible than what the core PM system offers for just daily task management. For instance, a billing manager might use a spreadsheet just to track the appeals process for high-dollar claims across multiple different payers.
More flexibility.
Exactly. And finally, call scripts and tracking templates are essential, especially for larger billing teams. Standardized call scripts ensure consistent communication when talking to payers or patients. They help staff ask the right questions, gather all the necessary info efficiently, and importantly, remain compliant with regulations. Tracking templates, on the other hand, ensure that thorough documentation during those direct interactions, capturing all the key details like rep names, reference numbers, specific next steps vital for that continuity we keep mentioning. What's insightful here is how all these tools, when used effectively and often in combination, can significantly streamline what would otherwise be an overwhelmingly manual process. It directly impacts a practice's ability to reduce DSO and improve the overall efficiency of the whole AR follow-up process. It's really about leveraging technology and standardized processes to make a highly complex job manageable.
Okay, so you've got the tools, you've got the workflow, but it's still not always easy, right? Even with all that, there are still common hurdles in AR follow-up. It's definitely not always smooth sailing. Our guide doesn't just list the challenges, though. It offers practical, actionable solutions, which is incredibly helpful for any practice looking to optimize its financial health.
That's absolutely right. Understanding these common pitfalls and, crucially, their solutions is critical for moving from that reactive state constantly chasing old claims to a more proactive, preventative approach. It's all about systemic improvement.
So what are some of the big ones?
Well, one major challenge is incomplete documentation. This is a root cause for a truly staggering number of rejections and denials.
If the patient's chart, or maybe the claim itself, is missing vital information like a detailed note justifying medical necessity for a procedure, maybe a clear consent form, or results from a test supporting the diagnosis, the payer will often just deny it outright.
Makes sense. They need proof.
Exactly. The solution, as the guide points out, is rigorous verification of claims before submission. It's all about prevention at the earliest possible stage, implementing strict protocols for data entry, ensuring thorough clinical documentation happens right at the point of service, and utilizing those pre-submission claim scrubbing tools can save immense time and effort down the line. It's so much easier and far more cost-effective to prevent a denial than it is to appeal one.
Prevention is better than cure, even in billing.
Definitely. Another significant challenge is a high denial rate. If you see this, it's not just about individual errors. It often indicates systemic issues within the practice's billing operations, or maybe even with a specific payer they deal with a lot. A consistently high denial rate means a big chunk of your submitted claims are being rejected right off the bat, leading to massive cash flow problems and mountains of rework for your team. The solution here is to use denial analysis reports to identify patterns and root causes.
Finding the patterns.
Exactly. Are certain procedure codes consistently denied across the board? Is one particular insurance company denying claims for the same reason over and over again? Once you identify these patterns, the practice can address them at a higher level, maybe through targeted staff training on correct coding, maybe updating internal documentation policies, or even engaging directly with the payer to resolve systemic issues or what seem like unfair denial trends. This is where really digging into those CRKey error and ART codes becomes a powerful strategic tool.
Okay, what else causes headaches?
Oh, we've all experienced this one, I think, either as patients or professionals, long hold times with payers. This is a huge frustration for billing staff. It just eats up valuable time that could be spent on other, maybe more productive follow-up tasks. Imagine a billing specialist spending literally hours on hold each day it happens.
Ugh.
Solutions. Well, leveraging those payer portals we talked about is key. They often provide immediate status updates without human interaction, saving precious minutes, sometimes hours. Another strategy is scheduling callbacks when the payer offers that option, or just shifting from phone-only strategies to utilizing online resources whenever possible. Some larger practices even employ dedicated staff whose primary role is just navigating these phone queues, freeing up other billers for more complex tasks. It's about being strategic with how and when you contact payers, optimizing for the most efficient channel available.
Working smarter with communication.
Precisely. And finally, a prevalent issue that can just silently kill a practice's revenue stream is a lack of follow-up schedule. Without a structured, systematic approach, claims can easily just fall through the cracks. They might sit in an aging bucket, getting older and older, until those timely filing limits expire, making them completely uncollectible. Lost money. The solution here is implementing automated AR work lists. These systems can automatically generate a prioritized list of claims that need follow-up on a specific day, based on their aging bucket, previous actions taken, or just a set schedule, ensuring consistent and timely follow-up. This prevents that out-of-sight, out-of-mind problem that leads directly to revenue erosion.
Automating the reminders.
Exactly. This really emphasizes how practices can shift from being reactive, constantly chasing old claims, to being more proactive and preventative. The solutions offered here all point towards system improvements, diligent adherence to processes, and continuous analysis. It's about building a robust, preventative system that minimizes the need for extensive firefighting later on. It's truly about working smarter, not just harder, to make sure every dollar earned is actually collected.
Okay, so we've covered a lot. What AR is, why it's so important, the whole step-by-step process, the tools, the challenges. But how do you actually know if your AR follow-up efforts are truly working? How do you measure success?
Our guide provides a set of key metrics to monitor, and these are really like the vital signs of practice's financial health. These aren't just abstract numbers. They tell a compelling story about efficiency, effectiveness, and ultimately financial stability.
Absolutely. These metrics provide that comprehensive picture of financial performance. They highlight areas needing improvement, and they allow practices to set concrete, measurable goals for their billing department. Let's delve into them. All right, what are the key ones?
First, there are AR days, sometimes called Days Sales Outstanding, DSO, which we touched on. This metric represents the average number of days it takes for a practice to collect payments from the moment a service is rendered. A lower number is always better. It indicates faster collections and healthier cash flow.
Lower is better. What's a good number?
Well, it varies by specialty, but for many, an AR day count consistently under 30 days is often considered excellent.
If you're consistently over 60 days, that can be a significant warning sign of underlying issues. If your AR days are consistently high, it just means money is tied up for too long, potentially causing liquidity problems and making it tough to cover immediate operating expenses. A healthy practice really strives to keep this number as low as possible, benchmarking against industry averages and definitely their own past performance.
Okay, AR days. What's next?
Closely related, and just as crucial, are the AR aging buckets. This gives you a percentage breakdown of your total accounts receivable by those age categories we talked about. 0-30 days, 31-60, 61-90, and that 91-120 plus days bucket. A financially healthy practice will have a very high percentage of its AR in that current 0-30-day bucket. Ideally, you'd like to see 80-85% or even more there. That means most of its outstanding money is very current and actively being processed.
Less in the older buckets.
Exactly. Conversely, you want very little, ideally almost none, in those 91-120 plus day categories, because those are notoriously the hardest to collect due to timely filing limits and other hurdles. Monitoring this trend over time helps you immediately spot if older balances are starting to accumulate, indicating problems in the follow-up process that need urgent attention. It's a very clear visual of where your money is getting stalled.
Makes sense. Then there's denials.
Yep, the denial rate. This is simply the percentage of claims you submit that get denied by insurers. A high denial rate is like a blinking red light on your dashboard. It signals underlying problems. Could be coding, could be documentation, patient eligibility verification, submission processes. Something needs immediate attention. For example, if your denial rate is consistently hovering above, say, 5-10%, that's generally considered a serious problem. It indicates a significant portion of your claims are being rejected on the first pass. This creates a massive amount of rework for your billing staff, it delays revenue, and it's just a significant drain on resources. Tracking this closely helps identify specific denial trends, maybe from particular payers or for certain services, allowing for really targeted intervention and process improvements.
Got to keep that number low.
Absolutely. Then there's the collection rate. This gives a broader overview of overall effectiveness. It's the percentage of the total collectible amount that has actually been received by the practice. It's a direct measure of how successful the practice is at converting the services they provide into actual cash. While a high collection rate, ideally 95% or higher for most practices, is highly desirable, you have to view it alongside other metrics like AR days. Why? To ensure that collections aren't just high, but also timely. For instance, you could technically have a high collection rate, but if your AR days are also sky high, it means you're eventually getting the money, but it's taking way too long, which still impacts cash flow.
Ah, okay. So they work together.
They absolutely do.
Yeah.
And finally, there's a critical metric that often serves as a kind of leading indicator, something that drives improvement in all the others. The first pass resolution rate, FPRR. This is the percentage of claims that are paid correctly on the first submission without needing any rework, resubmission, or appeal whatsoever. A high FPRR is really the gold standard in medical billing.
Getting it right the first time.
Exactly. It indicates that the claims are clean, they're accurate, complete, correctly coded, and that the initial processing on the practice's end is highly efficient. Aiming for an FPRR of 90% or higher is usually a sign of a very healthy billing operation. This directly reduces the need for all that extensive AR follow-up later, because if a claim is paid correctly the first time, it doesn't even enter that complex, time-consuming follow-up cycle we've been discussing.
That makes a huge difference.
It really does. And what's truly insightful here is how these metrics are all interconnected. Improving your FPR, for instance, directly lowers your denial rate because fewer claims are getting rejected initially. A lower denial rate contributes to a better AR aging profile, right? More claims get paid quickly, sitting in those desirable 0-30-day buckets. This, in turn, ultimately helps reduce your AR days and significantly boosts your overall collection rate. They really do paint a comprehensive picture of financial performance and highlight exactly where the strengths and weaknesses lie in a practice's revenue cycle management. Focusing on these metrics allows a practice to continuously refine its processes and ensure long-term financial stability, which ultimately frees up resources to invest back into better patient care.
Wow. We've truly taken a deep dive into accounts receivable follow-up in medical billing today. I mean, from understanding what AR even is, that money owed to providers for services they've already delivered, and why it's so incredibly vital for a healthcare provider's cash flow and just their operational stability, to walking through that intricate step-by-step process of how claims are actually tracked and resolved. We've explored the essential tools that make this complex management possible, identified some of those common challenges that can really derail efforts, and finally looked at the critical metrics that measure success and guide continuous improvement. You hopefully now have a really comprehensive understanding of this often overlooked, yet critically important administrative function that, as you said, really underpins the entire healthcare system.
Yeah. And when we connect all this back to the bigger picture, it becomes incredibly clear that efficient AR follow-up isn't just about, financial numbers on a spreadsheet for one medical practice.
Yeah.
This entire process, as complex and administrative as it is absolutely essential to the sustainability of healthcare services, really, globally. It makes you wonder, doesn't it? Imagine the broader impact on patient access to care if providers simply couldn't reliably get paid for the services they provide.
Yeah, the whole system would crumble.
It really could.
Yeah.
If clinics and hospitals constantly struggle to meet payroll or buy necessary supplies or invest in new life-saving technologies just because of persistent delays in collecting what they're legitimately owed, the quality and even the very availability of care would suffer dramatically, and that affects everyone. This crucial administrative work, when it's diligently executed, is what truly allows our medical professionals to focus on what they do best, which is caring for all of us.
A really powerful closing thought. And that's our deep dive for today. Thank you so much for joining us on this journey to becoming more informed. Until next time, keep digging, keep questioning, and keep learning.